Please go ahead and continue to enjoy your lunch. We're going to have our keynote speakers now, and to introduce our speakers are going to be Nancy Flanagan from HSM and Elliot Ball from Informatica.
Good afternoon, everybody. I'm hoping that not everybody enjoyed all the cookies, or these poor gentlemen are going to have to deal with the sugar crash that will be coming soon. So with that in mind, I'll go along here. And I feel like being at the JFK Library, I should slip into my Boston accent and be wicked cool like my mother and introducing Todd Bravo. And Todd is HealthInfoNet's Chief Technology Officer and provides the technology, vision, and leadership for all technical aspects of the company, including system architecture, strategic planning, operational, system management, acquisition and deployment, data integrity, and information security. It's a lot, Todd. In his prior role at Northrop Grumman, he managed project teams of up to 300 people on nationally recognized programs such as the U.S. Armed Forces Health Longitudinal Technology Application, the largest electronic medical record system in the world. With 20 years of experience, primarily in directing technical projects, he has provided business and consulting services to a range of Fortune 100 companies, including defense, telecommunications, manufacturing, and natural resource industries. Todd has a master's degree in public administration and is a certified project management professional and a 2012 graduate of the Hanley Center's Health Leadership Program in Maine. So, Todd, come up and thank you all.
Yeah, we're just introduce her.
Oh.
That's right.
I'm up on stage now.
Good afternoon. My name is Elliot Ball. I am from Informatica. We're one of your new premier sponsors, and really looking forward to getting to know the organization and helping as we can on future meetings. So I get the pleasure of introducing Eric Widen. He is an ex-East Coast guy from Worcester, Mass, I believe he just told me. He's now residing out in the Bay Area in California. He is the co-founder and president of HBI Solutions. Prior to this, he oversaw performance improvement and clinical analysis programs at Lucille Packard Children's Hospital. Seems like he has extensive experience on all sides of the fence, as a consultant, as a vendor, as well as on the provider side of the organization. So with that, Eric.
It's always nice when technology works. So it's a good start here. So thank you again for inviting us down here to present today. This is a wonderful day. I couldn't do anything about the weather. I apologize. It's not any better in Maine. But I'm really excited about our presentation today. We do have a PowerPoint presentation. We're going to walk through a few slides, but what's really exciting to me is what we're doing in the field today. We're going to bring you right into our system. It's not our live system, but it's a kind of de-identified copy of our live system. We're going to actually show you some of the analytical work that we're doing up in Maine today. To really give you a background on our analytical arm and services, what I want to do is start off with a few slides really around our HIE background. So we're going to walk through our connections, key statistics, and then go into HBI Solutions background, why we chose them as a partner, and we've been working with them for the last year and a half. And then go into our analytical service and go into more detail there about the technology used, exactly what we're doing to really change healthcare, how it's being kind of managed today, especially from an accountable care organization perspective. So a little bit about HealthInfoNet. How many of you have heard about HealthInfoNet? Okay, good. I'm happy to see some of my vendors in the audience are raising their hand. That's very critical and important to us. Don't forget about us. That's wonderful. So HealthInfoNet, here's a little elevator speech. We're a private nonprofit funded by both private and public sources. of funds. We're an independent organization. We're not owned or affiliated with insurers, hospitals, associations, or state governments. So we really try to remain that kind of neutral position in the state of Maine. We're the state designated HIE for Maine. And we started as a project back in 2004. And then the organization was founded in 2006. And we went through 2 years of a demonstration phase that started in December of 2008. It went through July of 2010. And I've been with the company for about 4.5 years now. So I got to see the end of the demonstration phase all the way up to today's, how we're structured today as an organization through the state. What's really fascinating to me is we've grown tremendously, and you'll see over the next few slides here. So I encourage everyone to visit our public website. We have a wonderful little tool where you can sort and filter the different hospitals connected, FQHCs, private practices, et cetera, throughout the state, and find out more about what data they're sending to us. Overall, we're connected to the 34 out of 37. They're all under contract. These are hospitals in the state of Maine. We have 34 FQHC sites. I think that boils down to about 15 federally qualified health centers, but they have that many sites. They're actually sending us data. Many of them are sending us data today. And then 400 ambulatory. That includes, private physician practices, behavioral health, and long-term healthcare facilities. When you think about the ambulatory sites on the physician side, that's about 50% of the marketplace in Maine is actually sending us data today. So this is, as you look across New England, you can see HealthInfoNet has been around for a while, and as other HIEs are maturing and kind of going through this, you'll see more and more connections. Hopefully one day we'll have a New England-wide kind of HIE exchange, and then we'll go beyond New England, go down to Florida. Here's some key statistics, and I think these numbers are impressive. Of course, I'm a technology guy, I like numbers. But just in terms of the number of lives covered, it's just amazing. So we have 1.3, and you're thinking, how's that possible? Maine only has 1.3. You already have more lives covered than there are in Maine. Well, this is, we like to take advantage of those people who come to Maine, they end up in our hospital system. Unfortunately, they have a ski accident, whatever it is. We do count those lives. We do capture information on them. We don't do a lot with that information unless people go look for them within our clinical portal. But out of the residents of Maine, we've captured 88% of the Maine resident population, so that's the 1.2 million number up there, which is really impressive. If you go to the clinical portal today, you have a very good chance of getting some clinical information on the patient, Todd Bravo, whoever is in front of you. So that's really valuable. We are an opt-out state, so that means everyone is in by default. But when you go in for treatment, whether it's in the primary care setting or in a hospital setting, it's a state-mandated form, and you're given that form, and you can opt out. You can opt out from any location. Once you do that, we centrally manage that, and we delete your data, so we remove your data from our systems. If you choose to opt back in, it's a mistake, and we do have people who go, oh my goodness, I didn't realize that. We let you opt back in. We don't go back and pull historical data. We just move from that data forward. So that's kind of how we operate in the state of Maine. Right now, we have just over 2,000 active users. Active users are users who have been in our system for the last 6 months with activity that we see. And that keeps their account active. But 2,000 is a steady and growing number. And then 60% of those, as you can see, were active in the month of April. So we're seeing a very good return. We have some kind of infrequent users who come and go. We have some care managers who use this every day. We have some practices that have worked this into the workflow where it's something, the day before the patient arrives for the appointment, they go and look up their records and kind of pull together that information ahead of time. What's really impressive to me is this very complex, too many numbers on the slide, but I'll give you some context. When I joined HealthInfoNet, we were collecting 160,000 records a month, and so now on a monthly basis, we're up to over 13 million messages which come into our system, which is really impressive. So an average weekday, we're seeing over 600,000. So it's just tremendous growth in terms of the intake side, what we're taking. Then on the sending data out of our system, we used to send, it was very low. I think we were doing some reporting to main CDC, so we were, in the hundreds. Today, if you look at these numbers, 150, about 160,000 of clinical messages going out in support of ACO organizations throughout the state. That's information we're taking and feeding back out to these other organizations for treatment purposes. 61,000 data transmissions sent to main CDC. And this is mainly driven by meaningful use, and you can see the 3 measures that we currently support here. This number continues to grow. And at least in the state of Maine, they see this as a tremendous opportunity since we are a real-time system. This is real. Real-time means 5 seconds. So you get it administered at a hospital, we get that message to us within 5 seconds. We also have reached a new high here of just over 21,000 patient lookups every month. So those 2,000 active users are generating that much patient lookups. When they go into our clinical portal, they get a really good comprehensive summary of patients, including medications, lab test results, obviously their demographics, allergies, active problems, immunizations, vitals, it goes on and on. Continuity care documents. So this is a relatively new thing for us. It's not a new concept, but we've started to send this out. What's new here is we're sending out CCDs in an XML format, which discreetly goes into the EHR. So we're doing this with one of the largest systems in Maine right now, where it discreetly gets carried over, presented in the EHR. This has always been one of my visions. And I knew an HIE had to get there, and I think everyone in this audience knows this as well. Clinicians they don't want to go to 5 different places to pull information. So they mainly go to their system of choice, and that's typically the EHR that they use. And so my challenge has been, as an HIE, I would love to have them come to our clinical portal, but it's really a secondary system. So my challenge has always been, how can I get our information that comes from the broader community, patient-centric, into their system where they don't have to go elsewhere. So we're starting to do that now. So it's taken years. We're starting to actually do this, and it's paying off. And then real-time notifications, extremely important. We've reached a new high. This service has only been available for the last 6 months. We've just seen exponential growth every month go up. Accountable care organizations have, some of their populations are over 50,000. We track all of them. We have about 10 different types of notifications that are set up today. Todd Bravo has been admitted into the ER, discharged from the ER, admitted to the inpatient setting, discharged from a skilled nursing facility. So we have just the tip of the iceberg going on here. And out of those 8,000, we have 600 of those, which are daily summary reports. And so you can just imagine some of the ACOs who have signed up have only signed up for daily summary. And you can have a whole list of patients every day that comes out. So really that number should be larger, but this is our real-time notification. So just really exciting. So, we've grown from a system that, only used to intake 160,000 messages a month to over 13 million. On the sending data out, it used to be hundreds, and now we're up over about 240,000 if you add those numbers up, roughly. So it's just amazing in the last 4 years what's been accomplished. And this is just a technical thing I threw up there. So we don't capture images. It's all text-based if you think about it that way. And our database, our core database, has grown to just over 2 terabytes in size. It's not overly huge, but it is substantial. And it continues to grow every day and presents a challenge. But this actually, with now 4.5 years of data that we're sitting on top of, the second piece I've really been focused on and why we've partnered with HBI is really how can we leverage that? There are 10,000 ways that everyone in this room can think about how to leverage the data, but we need to do this with keeping the treatment of the patients in mind. That's our goal and mission. And analytics is such a broad category, but we're going to get into today to show you exactly what we're doing. We have people under contract using this service today, and that's what I'm excited about. So I'm going to pass it over to Eric, and I'll stay up here and hover around, make him nervous. But if you have any questions on the HIE side or on the analytical side, I may shift some to him, but Thank you very much. Thank you, Todd. All right, so I'm president of HBI Solutions, and we're a data analytics company located in Silicon Valley, strictly focused on healthcare. And so we work with hospitals, health information exchanges, physician practices. I moved to California about 15 years ago, haven't shoveled snow since, and after this winter I'm going to continue down that path, not shoveling snow for sure. So HBI, like I said, we're focused on healthcare analytics, and we're a team of both kind of industry professionals in terms of health IT, really working with data, driving improvements within organizations, providers, and physician practices. And we also have a research arm to the company as well, where part of the company is comprised of Stanford researchers. And I'm going to inform you that we are a population health and predictive modeling company. I know we're the only one in the country doing that right now, so that's a surprise. I just learned that Jimmy, the bartender in Quincy, is also doing population health. He has no product, but he has excellent slides, which qualifies him as much as anybody else saying they do this, right? So we partnered with, when we first started getting engaged with HealthInfoNet, they were really looking for a way, like a lot of public HIEs out in the market today, how do we become more sustainable, provide more value to our clients, and a key component to their thinking around that was analytics, and so that's kind of how we got together in the first place. And an HIE, specifically the one in Maine, has a very rich longitudinal history on all patients throughout the state. So Todd gave you some of the statistics about how many people they have, but in terms of clinical information that they have all the physician office visits, all emergency department visits, all inpatient activity, outpatient medications coming in, and they store it centrally, right? So there's different models out there. A lot of the federated models ship CDA or CCP documents from point A to point B, don't capture that data centrally, but in Maine they've got that data captured centrally, which provides a really rich clinical environment to do advanced analytics on top of. And so in terms of use cases, and a lot of organizations are dealing with this today, right? So as payment transformation happens and people go from volume-based to risk-based contracts, the analytic underpinnings for that is a requirement. The pressure reduced cost has not ended any time previously, or is it going to in the future? Regulatory requirements continue to be hammered down on organizations as they have to produce data for different purposes, for different regulatory, and again, around aligning clinical data for the treatment of disease are use cases that are out there. And so, what you see around there for solutions, you see forecasting, predictive modeling, population health, cost management, quality reporting. And so a lot of the vendors out there are producing these solutions. Why kind of we founded this company is, part of it was when I first started a career 20 plus years ago, organizations didn't really use data to the extent they should to drive the organization forward. And I think little has changed in the past 20 plus years. And so what has changed, though, is the adoption of EMRs has certainly created more data for people to take advantage of. And then computational power has certainly increased in that time period as well. And so, the puzzle pieces are in place to put together more robust solutions for organizations. Some of you may have seen this. This is a Davenport model whose research has done a lot around the maturity of analytics. And I know HIMSS has that. And so as organizations think about how do we go from 0 to 60 as we drive analytic solutions into our organization, there's different models to think through, and there's boxes to check, right? Are we at level 1, 2, or 3? But at the end of the day, how are we going to use the data to drive value? How are patients going to get healthier, and how are costs going to go down? And that is really all that matters, because we'll spend millions of dollars on ICD-10, little value goes to the patients, data warehouses are getting implemented, then people think about, okay, now what do we do with these data warehouses to solve problems in your organization? So it's important to think through the value first as you think about analytic solutions. And so I'm going to describe a little bit technically, and Todd, let me know if I say anything incorrect about this, but what we've taken is the HIE data and loaded into our data platform. And so part of that was in place. So the HIN does a lot of the data standardization, so they get data from 40 plus entities throughout the state. They have to normalize that data. So a CBC is called a CBC, is called a CBC throughout the state. So they take care of a lot of that standardization effort and provide that normalized database out of the gate. And that's what we've loaded into the HBI platform. And
immense amount of the work is just cleaning the data and getting it ready for analysis. You can't circumvent that effort, but that is a bulk of the work because there are not a lot of standards from a data standpoint today. And in terms of the analytical platform, it's largely, so the analytical platform is Microsoft, and so it's all housed in Microsoft technology. But the value comes into what are you analyzing and how are you driving value from that in an organization. And so we take the source data, we bring it into this analytical environment that can be sliced and diced in a million different ways, and we think through what are those use cases on the back end that are going to be important to providers to drive improvement. And so with Murphy's Law aside, I'm going to try to do a demo of the actual system today, but what I'm going to focus on, so there's a couple use cases already used today, right? So there's hospitals and physician practices actively using this system on a daily basis throughout Maine through the Health Information Exchange. And it's a couple different flavors from a risk management standpoint. So there's population risk, right? So if we're people out here, who's going to show up in the ED in the future? Which one of us is going to show up in the inpatient setting? Who's going to be high cost? Who's healthy that's going to be pre-diabetic? We're loading a series of these population-based predictive models in so that care managers that sit either in an ACO, they sit in a primary care practice that are getting fixed per member per month to manage. These are the types of people using the system today to proactively manage populations. The 30-day readmission risk models, that's kind of encounter-based, right? Patient in a bed today, sitting in a hospital, what's their likelihood to come back in 30 days? And there are care managers that either sit in the quality department or part of inpatient care coordination that are using that today throughout Maine. Then we've got a series of other ones, time aside, that we also provide to the end users. So there's variation management. So when we're collecting data, what's the variation in care from either a resource utilization standpoint, how does length of stay vary, part of the future work, and we'll talk about this at the end, is right now the data is largely clinical in nature. So HIN is getting HL7 transactions from all the providers throughout the state. And includes some of the AEP information, which provides a great clinical profile. And we're moving forward to get more billing level data and claims data from some of the payers to then provide a rich resource from a cost standpoint so we can start doing variation management throughout the state by disease, by population, by area, by physician, to start honing in on where's their variation in care and how do we manage and mitigate that. And then part of what's interesting, which came to light also, is HIN is a real-time transaction system. So they get by the minute updated data as it occurs throughout the state, and it provides real-time market intelligence. So we're able to load this into market and volume share dashboards that provide you, as of yesterday, how are things shifting as we think about our strategies of hiring physicians or what market we ought to have throughout the state. Typically that data is about a few years, typically a year old, sometimes 2 years old, depending on your data source for that. So a little bit about risk modeling. So as from a research standpoint, the researchers in the company, they have a broad background, a bit of kind of a diverse background in biomarker modeling on genomic and proteomic data. We've taken those methods and applied it to electronic medical record data. But the output of this at the end of the day is your risk of having an untoward event that we've loaded, and I'll give a demo of that. And basically we score patients by probability. So you get scored 0 to 100, and that's your probability. If you're 80, you're 80% likely to have this event. All right, so I'm going to switch over to the demo.
So just because we talked about security before, we can't tell you what data center we're hitting, but it's out there somewhere.
And we are through a VPN.
And we are through, yeah.
All right, so I gotta look at this over here.
All right.
All right, great. So I can't see it here, I can see it there, so if I talk. So what you have here is a population profile. Okay, so in the upper left, there's 1.2 million people in the database. Todd referenced 1.3 million people. We don't go back all the way to time when they started HIM. We go back the last 3 years or so. In the last 3 years, we're about 1.2 million people who had activity in the Health Information Exchange platform. And so there's two ways to look at risk. One is a profile tool, so you understand the number of people, the types of people at different risk levels in aggregate. So you can start from a planning standpoint, think about how many people are high risk for ED events or inpatient events, by what disease and so forth. So to orient you to this visual here in the upper left, these are the number of people in the database. There are general demographics here. Here we can see the age distribution of that population of the 1.2 million people. This is all the people in the state. We've got a gender distribution, where they live in the state. And so if you're so inclined, you can drill into and start looking at, this is a county level, and you can drill into the county, to specific cities within a county. And you get a payer mix here. And then we've got 3 risk models live today on these patients throughout Maine. So these 1.2 million people, the 3 risk models are, what's your likelihood of being high cost in the future? And we define high cost as, what's your likelihood of being in the upper 10% of most costly patients throughout the state? The upper 10% consumes about 70% of all healthcare resources in this population, and that's generally true with other research. The second 2 risk models we provide are your risk of an inpatient admission. And these risk models refresh nightly. And another comment on it, it's total population risk, so it's all ages, all payers, all diseases. It's not just Medicare or Medicare claims or CHF. It's all of them. So every patient gets a risk score throughout the state. And then the third one we have is risk of having an ED visit in the future. This is all based on the future 6 months. When we looked at time to event curves, if you're going to have an event, you typically have it within a 6-month period. That's why we chose that as the outcome period for this study. And then on the right, what we have are easy filters. So if you want to filter by age, or gender, or payer, you could do that. And so we could also look at by facility. So for a specific facility, I'll use, say Hospital 26 is at risk for capitated payments for a certain population. So what's also key is the patient attribution model, right? So with my payer, if I have an ACO panel, I look at the patients in my ACO. If I have a primary care practice, I look at the patients in my primary care practice. And we're actively working with the HIN folks to develop those multiple different patient attribution models, because there's multiple ways people are going to perceive their patients, right? And so here we've got a facility attribution model. And so this is for Hospital 26, that's any patient that visited the hospital last year. That's part of the data use agreement in Maine, that if you've established a care relationship with these patients in the last year, you can see these patients. And so now there's 41,000 patients that this group has. And if they had a group of care managers that were responsible for managing ED visits, they could say, okay, I want to understand how many patients are 70% more likely to have an ED visit in the future, and that 41,000 will whittle down to just the highest cost patients. But this is high level. So now we've got 455. I just got my first prescription for glasses, and it's killing me. I'm not wearing them. So there's 455 patients that are 70% more likely to have this ED visit in the future. So that's great. It gives you a profile information. So you can say, how many people do I have? But the care manager is like, I don't care about any of that. I want to know who the patients are. Right? So then the second module we have around this is an actual patient list. Let's minimize this a little bit. And so then I'm going to pick, so I got Hospital 26 already selected. And so then there's 40,000 patients that are attributed to Hospital 26. And now I want to see those patients that are, again, 70% more likely to have the ED visit. And these patients, this is all blinded information. I know we had the security guy here earlier, it makes me nervous. All right, so then you can quickly filter down to that level number of patients. So this will filter down. Now we've got 587 patients that are 70% or more likely to have the ED visit. And then we can say, okay, I want to see an individual patient. And I'll pick, let's see what here. And then we can bring up a profile for a patient. So what you get here is, now this is an individual profile of a patient. Individual profile of the patient, right? So the risk care manager really like, I want to see this patient, I want to see their history. So what we do is we trend the risk scores. This gets important. I can tell you today what's going to happen, but what's also important is what's the risk. Who's gone from low risk to high risk, or who's gone from low risk to medium risk in the last 3 months, right? So capturing the trend of risk is also very important, because again, be proactive. Because what care managers will tell you is, I know who the crash patients are. I know the person who visits 12 times a month and has 10 chronic diseases and I see every day. What I don't know are the people who are starting to use it and increase up the risk ladder. And so that's why you capture the historical risk here. And so the bars are related to visits, right? So the red bars are ED visits by month, the orange bars are outpatient visits by month, and then the line bars, the lines are your historical risk. And so the blue bar here is your risk of inpatient admission. So they're very high risk for ED visits, and you can see that because they've had a lot of ED visits in the future. We also provide other information in terms of demographics on the patient, their name, their current risk scores, their visit history, right? How many times did they visit in the last 12 months? And you can see this person's had a heck of a lot of ED visits. That's an obvious major driver of risk. And then we provide other information that's within the HIN portal that's to supplement the risk score. So why is this patient at risk? Well, they've got 8 chronic diseases, and here they are. These are the meds they're on. This is their abnormal labs over the last previous history. And then we get into what's their encounter history. And what's great about HIN is they get it from all providers, right? So maybe they just see my ED once, but they're also seeing 7 other EDs at the same time. And so you get all this information in addition to the risk scores. So we're trying to utilize the rich information that resides in the Health Information Exchange portal to supplement risk. This is what the care manager is using on a daily basis from a population standpoint. Now I'm also going to show readmission risk. So this is a very similar look and view, but the flip here is it's an encounter-based model, right? So a patient had an inpatient event, what's their likelihood of having another one in 30 days? So just a different way of using risk models for that. And so I picked Hospital 6 here to look at, and all right, so it's on 2014. So these people had 5,000 discharges in the last year, and this is the risk of each of these patients that have been discharged from this hospital, and that's their risk profile for all of them. And we supplement that information with chronic disease and demographics and the other stuff. But they also want to go right to the patient list. Show me these patients, who they are. And so similarly, we've got Hospital 6 shown here, patient with 30 or greater risk, and then the folks can click on an individual patient. You get the same profile, but you can then start understanding, because this patient's interesting, right? You get their history of different risk scores as they visited different institutions. You can see it's slightly gone up as they visited multiple times in the previous history. So quick. I'm told I talk really fast, so I just want to make sure I'm taking my time. We got a time limit too. Any questions around this? Maybe we'll save them to the end. We get through one. Let me, go ahead.
On the 30-day readmission prevention, there's all these risk tools out there that hospitals are using.
Yes.
And how does that interplay with what you're offering for your?
Well, it's either or, right? I mean, or both. And so within, the Health Information Exchange platform, this is accessible to all hospitals, or offered to all hospitals throughout the state. Not all of them are using it today, but we've got several that are signed up to use it, and others are looking at it. But that's exactly what we come across, right? We've already bought these other tools and so forth, and so this. Yeah, and I would say, working with HIN and working in the general market too, it's you come across this a lot. People have bought a lot of stuff. What we it always comes down to how you're using it, right? And some of them have similar features and so forth. But I would say what I see generally is that being more tuned to the specific risk, right? So for 30-day, just knowing their high risk doesn't tell you this. Here we tell you you're 80% likely to have the event. So the care manager only has to deal with 2 false positives out of the people at that level. So we try to be as specific as possible so that they have a real understanding of what they're dealing with and what they're not dealing with.
I think some of the other, a lot of analytics are done on claims data today. So when you're looking at real-time clinical, that's one difference. The other big thing was already highlighted by Eric is HealthInfoNet is collecting data from outside of the 4 walls. So you're really getting that really broad perspective on as the patient is the center of that and really understanding their care across, probably the majority of where they go for care and having that come into play in your analytics. So it's not that, tools are tools. It's more of kind of what data are you analyzing, how are you gathering it, the timeliness of the data. And then I think it may be important to note the pattern-based versus evidence-based if you want to touch on that.
Yeah, I think, so what we provide are learning tools, right? So these risk models refresh, they're tuned to this environment, right? And so we specifically took the Health Information Exchange data and said we're going to build risk models and tell you the score, right? So it's more of give me what you got, and we're going to assemble the best risk model as we can. And as we work with these folks and work with the providers, we're supplementing information as time goes on. So we're getting new data feeds, we're getting different types of data, we're doing things like getting NLP extracted data to add to the modeling environment. So we're going to continually take the more data in and rerun the risk models to make them better over time. Typically what you see with other commercially available tools out there is they're static. They say, you give us these 15 elements and we'll give you a risk score, period. And it's based on claims data, and it's probably based on Medicare claims data. Here, it's all patients, all provider, and it continuously learns in the background. So we use, as new data comes in, the models refresh. The modeling algorithm refreshes. Right.
So in a lot of ways, yours is better because it's more comprehensive and takes in all of the care.
Well, that's what I tell everybody.
I'll give you a commercial blurb.
She's my sister.
And I do want to say, so in the early days, this is going back over a year, what we did is we gave HBI the first 6 months of 2012 data. We said, go ahead, give us the list of patients that actually are going to present themselves in the ER in the next 3 to 6 months. They gave us the list. We took that list. We actually had the data because we were in 2013 at that time. And it was a 72% hit. So, it was, and of course, you're going to, as clinicians out there, you say, oh, I know Todd. Of course he's going to show you he's a diabetic patient. He's got this and that. Yeah. Well, what we're really going for here is not that, 90%, it's really the people who fall in the 70%, even 60. You want to know who's coming towards you. And then on the opposite side, you want to know who may be coming back. They're in the bed in the hospital, and you want to find out what is their risk of coming back if they're released today. And so we're looking at the results from the lab tests. I mean, that's what's really critical. I mean, claims data, you don't get the results. You just get that a test was done.
So I think we've got a few minutes left, so I'm going to flip through the last slides quickly and get right to the Q&A. I'm going to show you one of the main tools that are being used today within HIE. So current adoption, right? There's inpatient care managers, population care managers, and planning departments. So volume and market share I didn't show, but that real-time market intelligence is very much of interest to the planning departments within the setting. It's more of a byproduct of the level of recent information. And then we've had positive feedback. So this is like an email that came from a care manager. This is amazing, we like it, it's great. So, someone in a seat that's actually using this on a daily basis, they're not now getting 12 different, patient lists from 12 different payers to follow up on their own different formats. They get one comprehensive list. It's kind of streamlined her workflow. But, the tool is a tool. It's only one part of the people, process, and tools standpoint. So as we roll up our sleeves and work with the people doing the work, you got to figure out how to embed this in the workflow to make hay with it. That's not avoided, and this isn't that. It's not magic. That hard work still exists. But it is helpful. As I talked about for some of the future planning, more facilities keep getting added to the HIN environment. We're adding new data feeds, so we're getting into the hospital billing. We might be working with Medicaid claims data there. And we continually kick the tires on what information don't we have from the hospitals that we can bring in via HL7 feed to continuously learn. Strictly from a modeling standpoint, but also just from an information display standpoint as we think about other analytic tools. So I'll leave it open for questions if we've got time.
Is this on? You had mentioned about the importance of this with respect to sustainability for the HealthInfoNet, and I'd be curious if you could talk about, you talked about how many providers are sending data, but how many people are actually logging on, paying, what does the business model look like? Could you, and then I guess related to that is what does the return on investment look like? Because obviously you can see the benefits of reduced readmission perhaps in ED visits, but I assume there's some sort of financial analysis that you put forth as part of your pitch.
Yeah, so I'll pretend I'm the COO just for a second here, but so everyone is paying. We have the whole provider, it's mainly the provider community. We do have some federal grants. We were the recipients of the HIE grant. Those monies have come and gone, so we put them to good use. We were also the Regional Extension Center. We were able to pick up through that grant a lot of the independent practices throughout the state and kind of subsidize their fees. Those who have stayed on are paying now directly. So it's really the hospitals and the independent providers as well as, and solo doc practices up through. So that drives about 60, depending on what grant activities we have going on, 60 to 70% of our kind of core revenue that comes in the door. Return on investment is a really good question. So especially when you get into the analytical side like this, the way healthcare is set up, and this is no mystery, is you want to bring in Todd Bravo as a patient. You want to do every test under the sun for Todd to help him get better, number one, but also you're making some revenue off from that. So that it's a pay-for-service type of model. Unless Todd Bravo is under an accountable care organization structure where now you're only getting paid a set dollar amount to manage Todd's care. In those cases, we didn't do this research directly, but under a Beacon grant up in the Bangor area of Maine,
with Eastern Maine kind of heading up that initiative over 3 years, has come to a conclusion. I know there's some publications out there, but they've actually been able to reduce the cost of care. And we, HealthInfoNet, was very much a part of that. So that did drive our usage of the clinical portal. It helped bring them additional clinical information that they didn't have access to today. It's certainly not in the speed at which we can deliver it. And they were able to bend that cost curve. The problem in healthcare, which is not new news, is until we have that incentive to actually bring healthcare costs down without kind of hurting our bottom line as an organization. That's the trade-off. So if you ask a clinician, they see tremendous value in this because they're not thinking about the dollar side. If you ask the CFO or the accounting people, they're very, if you're under this program, it works extremely well. If you're over here, it's good to have. So we're still kind of, that's a lot of evidence is still kind of being played out, in terms of how that affects healthcare and how we're affecting it. But from my opinion, we're seeing a very positive impact. And this is the feedback we've gotten back from hospitals and providers who are part of the system.
You had mentioned some of the different risk models that you're looking at. Have you thought about bringing in other sources of information, such as medication adherence, diabetes management, compliance, as well as patient surveys about how they're feeling, maybe just depression or other situations?
Yeah, and so in this use case here, we're limited to the data that's within the Health Information Exchange environment that gets brought into the portal. The way the modeling works is we do take what you have, and so any data source we think is relevant to drive or be what you call a feature within the model that's going to be a predictor, we would take that in, model out, and see if it is in fact a predictor, to learn that that's in fact true. And as new feeds come in, whether the examples you gave or any of them, they come in, if we haven't modeled them before, we put them through that exercise to determine if that is in fact the case. So it's an approach, it's not a limit, so you basically take all the data that's available, and then the exercise tells you which ones are the strongest features that drive the model.
I think you bring up an excellent point. We're just hitting the tip of the iceberg here. I mean, this is really meant as, even though we've spent a lot of time on this together as partners, this is just the tip of the iceberg of the potential and the possibilities. And what's really going to drive it, unfortunately, will be some of the financial side, driving where do you go next in terms of whether it's savings, and then you have the patient care side, which is also going to drive things. So, I mean, we are kind of driven at HealthInfoNet by our customer needs, and so, I wouldn't be surprised if some of the items you mentioned kind of come up in the near future as they kind of drive us to collect the data, analyze the data on their behalf, and then through our analytics.
Related question, what's the technology behind the risk models?
Well, we use a statistical modeling approach, and so in terms of the software that we use, our open source R is the modeling software, but we've got the talent is really the people who understand how to take large data sets and take them through that exercise. But from a software standpoint, we use R.
I don't see anyone sleeping out there, so that's a good sign. So thank you for that.
Another question.
I have an unrelated question, but it's about the state of Maine. Are you guys doing something with behavioral health? And does it play into HealthInfoNet or not?
It does. So we're if you're familiar with the SIM grant, I think, I'm forgetting, don't quote me, I think there were about 6 of them that were given out across the U.S. So we are a sub-recipient of that grant, so we're a big part of it, and most of the work we're doing is focused on behavioral health. When you think about meaningful use, the whole behavioral health community was a little bit overlooked without going into the details. So we put an ask in from the state of Maine and worked with the state of Maine to put that and make that part of our SIM grant. So HealthInfoNet's role in that is we're going to be collecting this sensitive information, not substance abuse information, so that's the trick there, but behavioral, mental health information, bringing it in a format where it's an opt-in model, so you have to actually opt in. So we're going to be treating, especially if your whole organization represents and conducts these sensitive services for patients, we're going to be treating it differently, so it won't automatically be exposed in our patient or in their clinical portal, but it will be available, and when you break the glass and they give consent, then it will be available. On the back end in the analytics, again, it would also be made available to run a lot of further analysis with that extra data in play. One stance that we've taken in the state of Maine, when it comes to medications, prescriptions, we don't filter anything. So even though you could tell me there are some medications that are only given to people with a certain condition, we've taken the stance that it's not a diagnosis. So we bring in all that information right up front and we do expose that. So.
Thank you.
All right.
Thank you.
No, Bill, no, AD. That was excellent.